Good afternoon. Welcome to the Ear Research Foundation's first virtual webinar of 2022. My name is Christina DeFrancisco, and I am the Director of Communications and Development for the Ear Research Foundation. Today, we are excited to kick off our hearing education series with Dr. Herbert Silverstein and Dr. Lynette Dornton. They will be discussing hearing loss and over-the-counter hearing aids. Thank you for joining and supporting our mission. For more information about our organization, please visit earrf.org. Thank you.
Good morning. I'm Dr. Herbert Silverstein. I'd like to discuss hearing loss and over-the-counter hearing aids. Lynette Dornton will discuss the hearing aid portion of the talk. First, I'd like to tell you a little bit about our facility. We've been here almost 20 years now, which houses the Silverstein Institute and the Ear Research Foundation. The building is 30,000 square feet, and it's a treatment and research center for ear, nose, and throat problems. We have 6 physicians, a clinical fellow, number 48, 2 physician's assistants, 6 audiologists, and 48 support staff. My second business is being a jazz pianist and composer. I've been doing this for many years, making CDs and giving the proceeds to the Ear Research Foundation for hearing research. You can go on my website, herbsilversteinjazz.com, and get any of these CDs for free. If you make a donation, that would be great too. Some of the exciting research projects that we're involved in right now is injecting medications into the middle ear to get into the inner ear fluids to treat tinnitus or ringing in the ears, Meniere's disease, which is like glaucoma of the eye, where there's pressure, increased pressure in the inner ear, which causes vertigo, ringing in the ears, and pressure in the inner ear, and hearing loss. Also, we are injecting medications in to regenerate hair cells in the cochlea that will restore hearing and may have some patients not need hearing aids in the future. Other research we're doing is into numerous types of new implantable hearing devices to improve hearing. Before we talk about hearing loss, there's another problem of hypersensitivity to noise. Some people can't stand noise and the sounds are too loud to them. This occurs in about 7 to 14% of the population, and it's called hyperacusis. We became involved in this about 10 years ago, and I developed a minor surgical procedure to improve this condition, and we've operated on 65 patients, about 85 years to present time with good results. So what you'll learn today is the anatomy of the ear, how we hear, types of hearing loss, medical and surgical treatment, and electronic ways to make you hear. The ear is composed of 3 parts: the external ear, the middle ear, and the inner ear. The external ear has the auricle, which you're familiar with, the external canal, and the tympanic membrane. This is a picture of a beautiful eardrum, very normal. You can see right through it. It almost looks like a window, and you can see the 3 bones of hearing, which I'll talk about shortly. The middle ear comprises the tympanic membrane, the ossicles, incus, malleus, and stapes, the oval and the round window. The malleus is hooked to the eardrum and vibrates with sound stimulation, which then continues down the incus bone and then to the stapes bone. The inner ear is composed of the cochlea, hearing organ, the labyrinth, the balance and equilibrium, and the eighth nerve. So this is how we hear. Sound waves come in the ear canal here. They vibrate the eardrum. Little bones of hearing actually act like a transformer, increase the vibrations to the inner ear fluids. The little stapes bone sits in the oval window. And when the sound waves come in, stapes bone moves in and out, sending sound waves to the cochlea, which is here, which is shaped like a snail. And the basal end of the cochlea, the side that's near the stapes has the high frequencies and the apical has the low frequencies. Here you have the superior semicircular canal and the horizontal canal and the posterior canal, and they have to do with our balance and keeping us erect. Here's another picture of the inner ear showing the superior semicircular canal, the horizontal canal, and the posterior canal here. Cochlea as a snail. And then this cochlea is connected to the eighth nerve, which carries the brain, carries the sound waves to the from the inner ear to the brain, to the hearing center in the brain, which is then converts the sound waves to speech and sound that you've heard. This is an audiogram showing a normal hearing. The lower frequencies are here on the left side, and the high frequencies are on the right. The right ear is in circles and in red. The left ear is blue. 0 is perfect hearing, and you can have hearing up to 20% loss, which is normal, which is in the normal range. There are three types of hearing loss: conductive, sensorineural, and the combined sensorineural and conductive. We'll discuss the conductive first. Conductive hearing loss means that anything that blocks the sound waves from getting to the cochlea is going to cause a conductive hearing loss. The most common thing that we see in the office is earwax blocking the ear canal and blocking the sound waves. And this is usually caused by Q-tips being pushed into the ear and forcing the wax up against the eardrum. Also, fluid in the ear can come from the middle ear, from upper respiratory infections. There are perforations of the eardrum that can occur from Q-tips, from infections. Damage to the ossicles can occur from trauma to the head and from putting Q-tips in the ear or other objects in the ear. Sometimes there's fixation of the ossicles due to infection and disease of the inner ear, of the middle ear. Q-tips are not very good, and they should not be used. And yet they're commonly used to clean the ears. And what they do is they push the wax further into the ear canal. They're very dangerous and they cause perforation. They can cause perforations, hearing loss, and dizziness, and destroy the ear. We've operated on 27 patients over the years that needed surgery to repair the damaged eardrum and the ossicles. Some of these patients have lost their hearing, lost their balance, and really you should not use the Q-tips. So this shows a picture of what happens, and we just had a patient in the office yesterday that their hand slipped and they pushed the Q-tip right through the eardrum and caused all kinds of damage. So I developed a solution in an ear wash so that you don't need to use Q-tips. This is a safe method to keep your ears clean. It has a special tip on the end and to irrigate the ear canals with alcohol and aloe solution. And you can do this in the shower twice a week. This will help keep your ears clean. It's sold in our office and not sold on Amazon anymore. This is a picture of the tip here that you put into your ear. And you can see the head is tilted downward, and you put the tip into the ear and squeeze the bottle, and the ear will be flushed, and the solution will run out in the shower or over the sink. Usually will dry out very quickly because it's alcohol. Conductive hearing loss can be treated and fixed by most ear surgeons. We can fix the mechanical loss with or without surgery. If it's wax, obviously we can remove it most of the time in the office with instruments. So this just gives you an example of another type of conductive problem where there's a perforation of the eardrum here due to infection. And we can fix a little hole like this in the office. We take some fat from the earlobe and we can place it in that little hole, and we can close the perforation without the patient having to go to the hospital for surgery. The patient can also watch the operation on the TV screen while we're doing the procedure. The ear is anesthetized with Novocaine type of medication, and they feel no pain or feeling while we're doing the surgery. Another procedure I developed was called the laser stamp, was to restore hearing when the little stapes bone becomes fixed by otosclerosis. Most of the time we put in prostheses from the incus to the stapes, but in some cases the stapes is not fixed very much, and it can be mobilized by just cutting the part of the stapes with the laser, and we'll get the stapes moving and restore the hearing in the patient without having to have a prosthesis put in. The second type of hearing loss, the sensorineural, can be caused by aging, hereditary causes, noise, pollution, certain drugs, and diseases and tumors. This shows a typical sensorineural hearing loss on the high frequencies as we get older. And this is the most common type of hearing loss we see in the office. And in this type of hearing loss, patients complain first of not being able to hear in a restaurant. When there's noise around, they can't hear the sound. And they say, "What did you say?" They're asking people to repeat often. And it becomes annoying to the family and friends, and the patient usually will then come in for an examination. Too much sound can be detrimental and cause a hearing loss. 80 decibels of sound is loud, and we use earplugs or noise canceling earphones or move to a quiet area and not be exposed to this very loud noise. If you have a symptom after being exposed to loud noise or sounds such as hearing loss, ringing in the ears, or stuffiness in the ear, you should, this could indicate that there may be damage to the hearing. So this again shows the high frequency hearing loss, and where the damage is in the cochlea shows the high frequency loss. This little notch here indicates that there may have been some noise pollution or noise trauma to the ear at one point. There are several other types of sensorineural hearing loss. One is called autoimmune, which is a bilateral inner ear disease similar to Meniere's disease. There's fluctuating hearing, and the hearing decreases over time. Steroids and methotrexate are used to treat this problem. Another type of hearing loss occurs in Meniere's disease. This is usually a low frequency hearing loss. And this is treated with steroids by mouth or injected into the ear or put on a microwick and treated, and I'll show you that in a few minutes. Sudden deafness is usually caused by a virus and is treated with oral and injected steroids into the ear. This is the microwick that I developed in the 90s. This allows the patient to put the steroids or medications in the ear canal, and it goes down through this wick down to the round window membrane, which is similar to the cornea of the eye. It allows the medications to diffuse into the inner ear, where that's where they get to treat the problem, either the tinnitus, pressure, or the hearing loss. This procedure takes about 15 minutes. It's done in the office under local anesthesia with just some drops on the eardrum. And we've done this on many, many patients over the years. So the bottom line is that the sooner we see the patient after sudden deafness, the better the chance of restoring the hearing. Now, treatment of the hearing loss, if we can't treat it by medication or surgery, then hearing aids are available either for the sensorineural or conductive loss. And the hearing aids work for mild, moderate, and severe hearing loss. We also have implantable hearing aid devices that are good for moderate loss and also for patients that have single-sided deafness. The cochlear implant is reserved for patients with very severe loss where we can't improve the hearing with a device. Research has shown us that there is an association between cognitive disorders and hearing loss. And patients with dementia and Alzheimer's seem to have a problem with hearing in many cases. So this shows the brain here, a normal brain, and this is an Alzheimer's brain. So what happens is that the inner ear, the hearing does not stimulate the inner ear, the brain properly. And there's a deterioration of the brain over a period of time. The brain needs to be stimulated with sound to keep the brain functioning well. I wanted to give you a few takeaway pearls from the lecture today. So hearing should be maintained at a normal level to keep the brain active and functioning well. Sudden change in your hearing should be evaluated by an otologist as soon as possible to get the best chance of restoring your hearing. The longer you wait, the harder it is for us to get the good result. Tinnitus, especially in one ear, should be evaluated by an otologist to rule out any benign growth on the hearing nerve and also to determine what's causing the tinnitus. The best treatment for tinnitus is not to be in the quiet. No Q-tips in the ear. Use ear care twice a week, and you'll keep your ears clean and open, and you'll be able to hear without damaging the eardrum or the little bones of hearing. Thank you very much. Now, Lynette Dornton will talk about over-the-counter hearing aids.
Okay, so this is an audiogram of the right side is the red circles here. This is a person with kind of a mild to moderate loss. This would be somebody that would do probably pretty well with an over-the-counter hearing aid. Now, this is just the X's and the O's. This tells us how loud we had to make beeps before you could perceive them. These scores down here, I would argue, are more important. The right ear for this patient, they were able to understand 100% of the words being said. The left ear, if you look over here, much more substantial loss. This loss has been allowed to progress much longer. Their word understanding is 76%. If the best I can get you hearing in a sound-treated room with a guy with perfect diction is 76%, I don't care what hearing aid I put on you, you will never hear perfectly. The brain is where the magic happens. Okay, So, and that kind of leads into the ear has a very small role in the whole hearing process. Its job is to detect sound, and that's it. It's our brain that takes sound and turns it back into meaningful language. Sometimes people don't succeed with hearing aids because they have the wrong type of hearing aid. Every patient walks in my door wants this tiny little cute hearing aid, but unfortunately that type of hearing aid is only available for a niche product or a niche subset of my patient base. Recently, October of 2019, for us to find out exactly what an over-the-counter hearing aid was, when Grassley and Warren released that act, it was very, very vague. It was very short, and they gave the FDA 3 years to figure it out. There was a bit of a delay, but finally this past year, October of 19 of 21, the FDA did release their guidelines for over-the-counter hearing aids, and they are as follows. Any over-the-counter hearing aid has to obtain 510K FDA clearance. So what does this mean, guys? It means that every over-the-counter hearing aid that you see being advertised on television is not actually an over-the-counter hearing aid. They have been using the term illegally this whole time. There is currently only one over-the-counter hearing aid on the market, and it's this one. My hope is that all of the other companies that have devices on the market, they are called PSAPs, personal sound amplifiers. They are not allowed to have the OTC designation until they can do clinical studies, submit it to the FDA, and prove that their products actually do what they say they do. Of all the stuff out there, Bose so far is the only one to actually do this and get clearance. The really nice thing is they have an online hearing screening. They have rechargeable options. They don't have Bluetooth yet, but Bose is a pretty reputable company, so I have high hopes that that'll be coming. So we have over-the-counter legalized. This is awesome. Hearing aids are going to be cheaper. Is this the albeit solution though? And I'm going to play devil's advocate here for a moment and say, maybe not. Maybe just being more affordable isn't the solution. And I will cite some research out of the European Union. Here in the States, only about 20% of people that could use a hearing aid actually do. And we think, okay, that's because they're, quite expensive, which they are. I'm not arguing that point. But if we look over the pond at our friends in the European Union, they get hearing aids for free. There are 55 million individuals over there with hearing loss, but only 1 in 6 actually wears amplification. So if they're getting it for free and they're not wearing them, what the heck's going on? Why aren't people doing well with hearing aids? And that leads me to my case study. What is it that actually determines if a person is successful? Is it the type of instrument? Is it the provider? Or is it kind of a combination of both of those things? In my field or in my practice, I've been doing this about 15 years now. The most common reasons I see people fail are denial, number one. People like to think that other people have developed mumbling or speech impediments and it could not possibly be their ears. 2, people wait too long to treat a hearing loss. We know in every other area of our health, the sooner we identify a problem and treat it, the more treatable it is. But when it comes to hearing loss, some reason we want to kick the can down the road and wait and see how bad it can get before we treat it. And sadly, we're kind of setting ourselves up for failure in that situation, because the longer a loss is left untreated, the longer the brain goes without sound, and the brain is where the magic happens. 3, maybe the person comes in and they have a hearing aid that's completely inappropriate for their hearing loss. Luckily, that doesn't happen all too often. Number 4 is probably the most common reason patients in my practice I've seen fail, and that's that their hearing aid was not appropriately prescribed. A very expensive hearing aid that's very poorly prescribed can be a very poorly functioning hearing aid, and an entry-level device appropriately described can be quite effective. So I think Too much access to sound too soon is one of the errors that I see in programming. The other thing is that verification is not used. And I'm sorry, but can you hear me now is not verification that that hearing aid is doing anything. Okay, there is a very specific measurable way that we can verify a hearing aid is working, and I'll go a little bit into that in a moment. The last one is inadequate orientation or follow-up care. I'm going to skip over these for time's sake. Okay, so here I have two audiograms, right? I've got a right ear. This person has a mild to moderate hearing loss. This person probably would do pretty well with an over-the-counter hearing aid. I won't lie to you. This is a completely appropriate ear for an over-the-counter hearing aid. If you look down here, though, this is really the most important part. This ear has 100% word understanding. The X's and O's on these graphs don't tell us about language understanding. They only tell us how loud we have to make beeps before the ear can detect it and send it up to the brain. The word understanding is critical. So if I take somebody with this loss and 100% word understanding, hearing aids are going to be awesome. They're going to love them. If I take somebody with the other ear, right, with this left ear, they only have 76% hearing or word understanding. If the best I can get you hearing in a sound treated room with a guy with perfect diction at the perfect volume is 76%, chances are you are not going to do as well with hearing aids as somebody with a better score. Your brain has lost processing. Okay. Yeah, so ear, small role, detect sound, brain's where the magic happens. Sometimes hearing aids are not appropriate for a hearing loss. A lot of folks want this little tiny baby hearing aid, but guess what, guys? That's only appropriate for a very small niche population. Most of the time, it's going to be one of the over-the-ear types just because of the pattern of loss we see most frequently with aging and noise exposure. Okay, so hearing aids sometimes and most of the time just aren't programmed right. And I see this all day, every day in my practice. Either they're given way too much sound right out of the box, or maybe their hearing aid just was never actually prescribed. So too much sound too soon can be obnoxious. It's like being in a dark room for 20 years and somebody throws you into the blinding sun. I like to use a dimmer switch approach. I like to add a little bit of volume. Once the patient has acclimated to that, add more volume. This way there are no sounds that are uncomfortable or unpleasant during the acclimatization period. I find that my patients succeed quite well when I do it that way. Maintenance of hearing aids is important. You have to clean them. In my clinic, I see my patients quarterly to care for their hearing aids, do software updates on hearing aids, to clean their ears, etc. You need to have routine maintenance done on your car. You need to have routine maintenance done on your hearing aids as well. Many of you are probably well-versed in cleaning at home, but fun fact, I have a lot more fun tools. I have needle vacuums, I have suction chambers, I have all sorts of stuff that you simply cannot do at home. And if hearing aids are designed to last 3 to 5 years, it is my goal to have those last every minute that they possibly can. And I do that through routine follow-ups. Okay, so hearing aids are prescribed using this guy. He's what we use in acoustical research. His name is Kimar. And I have to talk about this a little bit for the next part to make sense. When we prescribe hearing aids, I'm not going to lie, it's not rocket science, right? We take this hearing test, we plug it into a computer. The computer pops out a prescription, but big but, that prescription is based off of this guy, Kimar. This guy has something inside his ear called a Zwislowski coupler that is exactly 2 cc's in size. Now, that is the average size ear canal. So every prescription that we create is off of the assumption that that person has exactly the average size ear canal. Well, unfortunately, every ear is as unique as a fingerprint. Not every ear is the same. And if somebody has larger than average, I'm under amplifying them. And if they've got a little baby ear, I'm over amplifying them. And if I don't measure it, I have no idea. So this is why we use real ear verification, which is the gold standard in prescribing hearing aids. What's happening here is I have a hearing aid in this gentleman's ear. This little thin tube is a microphone. He will be listening to a passage of speech that was designed a lot of years ago by a lot of smart people to adequately represent average English dialogue. And basically, I measure the output of the hearing aid to make sure that the hearing aid is doing what I need it to and what I think it should be doing. All right, so just to orient you with the graph, when I'm doing real ear, this is the graph that I see, okay? This red line is where the person begins hearing. These squiggly lines are what the hearing aid is doing in that patient's ear. I want my results to be in the white. I want my squiggles in the white. Okay, I'm gonna go over a couple, still have time. I'm gonna go over a couple of case studies, and that graph will be important as we go through it. But I want to make a disclaimer here. I am going to talk about a couple of specific products, but this is not advocating or putting down any service model or anything. I just want to show you the importance of an accurate fitting. Okay. So here is a 41-year-old patient. He got hearing aids from Resound hearing aids from a local Costco. He came in and he said he felt his hearing aids didn't really help him hear conversation. It really kind of only just amplified environmental noise. He had worn hearing aids or owned hearing aids for 15 years, but was honest with me that he didn't really use them often. So I hooked him up to Real Ear, and this bottom green line is how the hearing aids were programmed when he came in. So this guy is massively under amplified. So I used the software, I connected his hearing aids. I was able to get him pretty much within prescriptive targets, a lot closer than he had been. He was a happy camper, and his hearing aids did a lot better. And it had nothing to do with the hearing aid, it had everything to do with the fitting of it. Okay, next patient, 92 years old. She came down to visit from up north. She had just purchased top of the line Phonak hearing aids. That's one of the big 6 companies. From a reputable audiologist. She's worn hearing aids for a long time, but when she came down, she felt like her new hearing aids were just way too shrill and tinny. So again, I hook her up. The top green line is where she came in. And if you notice, she is way over, the squigglies are over the white area, and they're over the white area in the treble. So I made some adjustments. I brought her back into prescription, and her hearing aids were working much better. Okay, case study 3. This is a patient that is very close to my heart. He's a kind of a close family friend. He has a history of dementia. We had hearing aids on him. He lost one set. We got the replacements. He lost that set too. So his son went out and got him these Olive Pro devices, which, excuse me, at the time were called OTC, but if you take one thing from this talk, it's that the only thing labeled OTC that is OTC right now is Bose. So this Olive Pro would go back into that PSAP category. But it's cheap, right? $299. And the nice thing about this is it connects to the son's phone. The father can wear them. The son can very easily tell if the dad's wearing them because they're visible. So I said, yeah, bring him in. You know, I can't blame him for not wanting to spend another couple of $100,000, not that much, but I can't blame them for not investing in a whole new set of hearing aids given 2 losses in a year. So I say, okay, bring him in, let's get him set up. And all I have to control this is the little app on the phone. As it defaulted, this little green line is where it was. It's actually, I mean, it's under target. It's not terrible though. I just used the app to kind of tinker, and this is as close as I would get. Now that is one thing for any engineers or audiophiles in the group. Notice how peaky this response is. Okay, that is because of limited channels. This is one very large difference between over-the-counter hearing aids and prescribed. Prescribed hearing aids have many frequency response channels, and you see these nice smooth curves. Over the counter, they have less kind of fidelity, and this is something that the patient will hear in terms of sound quality. Okay, so moral of the story, I like to summarize with an analogy, right? So which guitar do you guys think sounds better? This fancy schmancy 1956 Gibson Hummingbird valued at just under 11 grand, or this more economical Rogue RA90 that I found on the internet, cheapest one on Amazon, $69.99. All right, I'm going to guess that most of you are going to agree with me and say the fancy pantsy one is going to be better. Okay. But now what if I told you that the one playing the Gibson was my nephew Abel, who has had no formal musical training? And the one playing the less expensive instrument is one Eric Clapton. I think that I can confidently assume that most of the attendees would choose the cheaper Eric Clapton option. And that's kind of how I feel about hearing aids as well. Over-the-counter hearing aids, prescribed hearing aids. I think that the quality of the sound you're going to hear is a lot more dependent on the person playing the instrument, be that the guitar or the person programming the instrument, the audiologist. It's a lot more based on their talent, their skill sets, than the widget, in this case, the guitar or the hearing aid. Yeah, so both hearing aids and musical instruments are going to sound best if the person playing them knows what the heck they're doing. Okay, ultimate takeaway, the end goal is to improve hearing. The way that I see over-the-counter hearing aids, and a lot of people in my profession hate that I have this opinion, I kind of like the idea of over-the-counter hearing aids. And the reason is I think of over-the-counter hearing aids as training wheels. If I can get people wearing hearing aids, over-the-counter hearing aids, when they do have a mild to moderate loss, they are going to be more successful users when they inevitably graduate into needing prescribed hearing aids. Because guess what, guys? The most common type of hearing loss is sensorineural. It's permanent and it's progressive in its nature. So if we can train the brain in an early stage to acclimate to hearing aids, then you're setting up an entire generation of people with better auditory processing that are going to do better with fancy prescribed hearing aids when they inevitably need them. All right. Another thing on the horizon is possible Medicare insurance or coverage for hearing aids. I don't know a lot about this. I do plan on giving another talk about this in the future, hopefully, once a little bit more information has come out. I do apologize.
I have a question.
Yeah, go ahead.
Regarding getting hearing aids from an audiologist versus going to Costco or Sam's for hearing aids.
Mm-hmm.
So I know that I have a friend who just went to Costco and got phonics.
Mm-hmm.
Phonak, which is one of the top 6 you said. So how does that How do the big box stores compare to going to a private audiologist?
Quality of care, follow-up of care, skill set of the professional. Now, I am not here to, sully any one specific route of obtaining hearing aids. The way that I see it, there's a lot of hearing impaired folks around, and we don't have to compete, as long as people are getting treatment for their hearing loss, I'm happy. But I do believe you will find a pretty large difference in terms of the quality of the diagnostic testing that is done. There's a slight educational difference between an audiologist and a hearing instrument specialist. An audiologist now has to have a doctorate, including at least a 1-year residency. We call it a fellowship in this field. Hearing instrument specialist, the qualifications vary state by state. I believe Florida, it is a high school diploma and a 6-month on the job kind of fellowship under an existing board certified hearing instrument specialist. I don't know their rules and regulations, so if I have misspoken on that, I do apologize, but to my best knowledge, that is the educational differences. When hearing instrument specialists perform testing, they perform testing for the purpose of fitting a hearing aid. When an audiologist performs testing, we perform it with the intention of diagnosing hearing loss and determining the origin of that hearing loss, determining all possible treatment courses for that hearing loss. Is it medical surgical? Is it hearing aids, etc.? Yes, so there's going to be a big difference in quality of care. What I will tell you is that if cost is important, Costco you can buy hearing aids at Costco cheaper than I buy hearing aids. That is a true story. My cost on hearing aids is more than you would pay at Costco. I don't know how that's possible, but it is. So I will never be able to compete with a Costco price for that reason. But also the service that a private audiologist provides, I like to think that they provide care structure similar to mine. And that is, I see the patient, I perform a consultation, we have a fitting. I see my patients 1 week, 2 weeks, 3 weeks after, where I'm gradually bringing them to full prescription. I verify that they're at full prescription using real ear, because again, if real ear is not done, you quite literally have no idea how that hearing aid is fit. Anybody that does not do real ear, not a fan. It's imperative. It's the only way we actually know what that hearing aid is doing. So yes, chances are you're not going to get real ear verification at a big box store. Chances are you're not going to work with an audiologist. Not necessarily the case. There are several audiologists that I know that work at Costco's and Sam's and whatever. And the follow-up care. Right? When you get a hearing aid from a Costco, they will say, okay, here's your hearing aid. Call me if you need me, never call me. I follow up with my patients like clockwork. I am very structured in how I do things. I see my patients every 4 months, whether they like it or not, because I am watching my patients. I'm looking at their data log. I know exactly how many hours my patients have worn their hearing aids, and if they have not worn them, let me tell you, I am very good at getting on a soapbox. My patients don't fail with hearing aids for that reason. I think I'm quite good at motivating my patients, I shall say. Did that answer your question sufficiently, dear?
I think so. My mother is 99 and has had hearing aids that are not working well at this point. And we did go to an audiologist this summer who tested hers in terms of clarity of hearing words, and she heard 20% with,
oh goodness,
and 80% with the ones the audiologist gave her. But I don't know, and I know the audiologist price range was like 4,000 to 9,000, but I don't know what she put on her ears. So at this point, I think my mother realizes she needs new hearing aids, but at 99, even the 4,000 is kind of like, do I want to spend that money? And so my question, and I had, like I said, I have 2 friends that had gone to Costco, and she got a pair of the Phonak for I think $1,400.
Mm.
So
So again, I guess the question is, what are we hoping for? Do we think that getting new hearing aids from Costco is going to resolve the problem your mom is having, in that she has a very substantial hearing loss? I would argue that she would be in better hands with an audiologist. A very entry-level hearing aid, and trust me, I have hearing aids that are way beneath $4,000. And if your mom is 99 and all she's doing is hanging out at home watching TV, she doesn't need $4,000 hearing aids. An entry-level set of hearing aids appropriately prescribed are going to be just completely adequate for her. That's why I take time when I do a consultation. I figure out, okay, what is my patient's loss? What are their listening needs? What's their lifestyle like? What is their budget? I've never wanted to put hearing aids on somebody and put them in a financial crisis. And I also don't believe that the only people that should wear hearing aids are those that can afford it, which is why my work with the foundation, putting hearing aids on folks is probably my favorite part of the job. Okay.
So I'm not clear if I'm understanding you. You're saying that the $1,400 ones would be a good thing, or the low cost ones at the audiologist for 4,000 would be a better?
I'm trying to find a way to explain this and I'm clearly failing. How well your mom does has nothing to do with the hearing aid. Okay, it has everything to do with the quality and the professional who is fitting that hearing aid.
Okay.
If you feel confident in the skill sets of the audiologist, I would consult with that audiologist and see if perhaps there are more cost-effective solutions for her. But given just what you've told me about your mother's poor word understanding, I would say audiologist, because they have a substantial benefit in terms of education to deal with those more profound losses.
Okay.
That help? Did I
Yeah.
finally answer it?
I think so.
Okay, good. All right, what do I think about the Meniere's diet? Oh God, the Furstenberg diet, that sucks.
I sent that to somebody.
Oh, yeah, that's fine. So I'll go ahead and respond to that one. Does it prevent, reverse, reduce, or do nothing? So as a person who tries to follow the Furstenberg diet myself, because I, fun fact, have Meniere's in my right ear and no usable hearing, I live by it. Some people have triggers for Meniere's. Some people do not. I would recommend cutting out one of those things at a time. For me, sodium, huge. If I even look at a potato chip with too much salt on it, I'm going to have horrible ringing and chances are I'm going to be spinning. Caffeine for me, not an issue. I couldn't go without caffeine or chocolate if you paid me to. So what I would say is try it. It has the potential to be very helpful, but you may find that you can continue the caffeine or the alcohol or the whatever, and it may just affect your body in a bit different. But yes, it is one of the recommendations we give to Meniere sufferers, and I have found it to be quite effective over the years.